Finance Committee will come to order. This morning, the committee gathers to discuss the challenges and opportunities in rural communities when it comes to health care. And I'm going to be blunt. Without rural health care, you cannot have rural life. It is just that simple. And yet across the country, rural health providers are struggling to keep their doors open. Gesundheit, Senator Langford. Too many hospitals, doctors, pharmacies, and other providers in our rural communities are now operating on a knife's edge. They're forced to choose between balancing the books and continuing to provide high-quality care to their communities. Half of all rural hospitals across the country operate in the red. There is no better example of this than what Oregonians in our Baker County experienced over the past year. In 1897, St. Elizabeth Hospital opened in Baker City and began to deliver babies. 126 years later, after being acquired by Trinity Health, the sixth largest hospital chain in the country, they closed their labor and delivery unit with less than 60 days' notice. Trinity basically said, delivering babies at St. Alphonsus was just a money loser. Nobody saw it coming. The people of Baker City thought their hospital could have a brighter future by joining Trinity Health. When I arrived at a town hall in Baker City last year, there were hundreds of outraged families, including a number of expecting mothers who had planned to give birth at St. Alphonsus. The next closest hospital in that part of eastern Oregon is 45 miles away, along a freeway that can be closed during the winter because of icy conditions. And there's also truck crashes. In fact, that hospital, the Grand Ronde Hospital in the Grand, Oregon, is here today, and we're so glad that Mr. Davis made the trek. I know a modest amount about most subjects, but when I really know something about it is airline schedules. And for Mr. Davis to get across the country to be with all of us today is a long trek, and we appreciate him coming. Despite efforts at the federal, state, and local level, St. Alphonsus in Baker City closed its labor and delivery unit completely last August. The community battled St. Alphonsus to keep basic labor and delivery equipment in Baker City in the event that the community can find their own solution in the near future. Rather than find ways to keep their obstetrics open, the hospital offered essentially a modest sum of money given their overall operations as the part of the sixth largest chain, $240,000. The lump sum amounts to less than $2,000 for each year the hospital has been in the community. What happened at St. Alphonsus is a textbook example of what's happening in rural communities across the land. Our view is these communities deserve better. These Americans deserve better. Between 2011 and 2021, 1 out of every 4 rural hospitals in America stopped providing obstetric services. That's 267 communities across the country where giving birth locally is no longer an option. So make no mistake, if it's not practical to give birth within a reasonable distance of your home, your community is facing the prospect of becoming a maternity desert. In these areas, aspiring parents are going to be forced to make tough decisions about where they live and where they start a family. Now, everybody knows that it's tough to get nurses, let alone labor and delivery nurses in rural areas. These hospitals see often a low number of births each year, yet face high costs to keep their services available. So today, I'm going to begin discussing a fresh approach with colleagues on this committee that combine steps that can address the economic realities in these communities with extra financial support as long as large hospital chains don't take the money and run. And my sense is that this is the kind of approach we can come together on and deal with the times. Let me mention 2 other areas briefly: telehealth and workforce. Telehealth is vital to healthcare in rural communities. It's a game changer for seniors to contact their doctor through a telehealth service instead of spending half the day or more driving to the health clinic and back home. It's enormously important for young families who no longer have to take the day off work to help their grandparent. I would just mention, and I think Senator Stabenow remembers it from working closely with me, Senator Langford as well, when Chairman Hatch and I came together to deal with the chronic care bill, the biggest single piece was telemedicine. And after we got it enacted, it essentially was sitting for a while. And one afternoon, I got a call from the Trump administration. They said, how would you feel about using our telemedicine provisions for the COVID challenge? And I said, you're calling from the Trump administration? You want to know how we'd feel that you'd like to use our telehealth provisions? I said, this is one of the coolest moments I can remember. I'm going to go off and have a hot fudge sundae to celebrate. Thank you very much. We're in. And those provisions that came from the Senate Finance Committee that were written in a bipartisan way, telehealth is part of chronic medicine. We're the law of the land. So there's still more to do. I think it is just defying common sense that clinicians in Idaho or Nevada have to jump through extra hoops and pay for multiple licenses just to provide care via telehealth to a family in Eastern Oregon. My friend Senator Cantwell, who's been doing such good work on aviation and a host of issues, I think is aware that a senior in Vancouver, Washington can't receive care via telehealth from a doctor across the river, across the Columbia River. I heard that we've got this new thing called the internet, brand new. We ought to be able to figure this out. With Senator Cantwell's, leadership, we'll be able to, and without mountains of bureaucracy. Last point I want to mention is the workforce issue. Healthcare jobs are so important as an economic engine for rural Oregon, but it's becoming more and more difficult to attract qualified healthcare workers to rural communities. One of the things we've got to do is update the graduate medical education program in Medicare to make sure rural areas and high-need urban areas aren't given short shrift. And we have to boost primary care. That's the backbone of the front line of American healthcare. Senator Stabenow's done particularly important work in this area. And we're also, as a committee, we've begun to do this, looking at innovative approaches like public-private partnerships to get into the high schools and start getting students earlier interested in healthcare. We've always talked about the community colleges. Every member here knows about that. I'm committed to getting more high school students, particularly juniors and seniors, into these slots and bringing them into the field. So lots to do here, and every member of this committee has an interest in rural and underserved areas, and we have a great panel of witnesses. And Senator Langford is sitting in for Senator Crapo. We hope his health is good, and Senator Langford's been a leader on this committee of a host of issues, including health care, but is also known as one of our leaders with respect to charity care, which has been very important to all of us.